minutes. It's pretty ambitious, but it's a very important topic, and I'll try and get through most of these. So the most important thing is to understand that when bacteria come in contact with the implant, they start colonizing the surface. They accumulate, and over a period of time, they form a large layer of these bacteria, and this is Staph epidermidis on polyethylene. And what it then does is, as these bacteria, these yellow blobs, come on this gray steel surface of the implant, some of them may get destroyed by these antibiotics and by some of the local cells of the patient. But as they start coming in contact with the surface of the implant, they start secreting a glycocalyx or a biofilm, and they start growing underneath that film, multiplying and multiplying. So the important thing is not to allow bacteria to come in contact with the implant, whether it is contamination, whether it is accidental touching of the implant to the skin, and then you have various other stages of this problem. So as this glycocalyx forms, some of the cells get liberated, they become resistant to antibiotics. That is the key point, that once it's colonized, the cells of the patient as well as antibiotics have no effect on this glycocalyx. So now, in order to deal with infection, let's look at the factors that we need to consider when we take a decision. So the most important are, of course, the host factors. What are the comorbidities, whether the patient is willing to undergo any further surgery, the patient's own preferences, and whether there's septicemia. Locally, you need to know whether there's a sinus, what's the soft tissue status, bone stock, what's vascularity of the limb, and is the implant stable. You need to know, of course, most importantly, the pathogen, virulence of the pathogen. Is it sensitive or resistant to antibiotics? How long has this infection been going on? That's, again, a key. And therefore, it's very important to make haste slowly. Don't be in a hurry immediately to start antibiotics without aspirating the knee, waiting for at least 15 days for the culture. Make sure the patient is not on antibiotics, because it's the key point to identify the bacteria. And then it boils down to us as surgeons and our team. What's our expertise in dealing with these problems? Do we have a good infectious disease expert, a microbiologist, and a plastic surgeon to help us in these complex cases? And lastly, what's our own environment where we have a fear of litigation? What would you do for these type of cases? So that brings us to 1 versus 2 stage revisions for infection. So in the first stage, in the 1-stage revision, you first remove the implant, do a thorough debridement, and then soak the knee in betadine and temporarily close the skin. You then re-gown, re-prep, re-drape, and then come back and put in a revision implant within a few minutes. A variation of this is being described by Leo Whiteside, who would also do a curve, that's antibiotic beads. So you have a big peak of antibiotics being released, and then it tails off below the MIC, which is, say, around 10 over here. And then the red one is the IV antibiotics. You just get a short spike. But with this intra-articular infusion, he has shown that you can have very high concentrations of the antibiotic, which persists over time. 2-stage revision really is removing the implant, doing a debridement, putting in a spacer, and then revising after an interval of few weeks to few months. In any case, the key step is debridement. And there are 3 modalities that you need to do. One is surgical, which includes extending the incision, excising the scar, curetting the sinus, removing the implant, and doing sharp dissection to remove the synovium, excise the membrane and biofilm, and send multiple tissue samples. You then do mechanical debridement of curetting the canals, removing necrotic bone, cement, power reaming, and using high pressure lavage. And finally, you do chemical debridement with whatever you're accustomed to using, whether it's betadine, chlorhexidine, etc. And then you repeat this cycle 2 or 3 times to do a thorough debridement. Now let's look at the results. 1 versus 2 stage for infected total knee. This is a recent systematic review. There are no RCTs. And this has shown no significant difference in reinfection. And in fact, for the first time, may provide superior outcomes in selected patients. So 2 stage has generally been considered the gold standard. But there's recent evidence showing that that may not be the case and that 1 stage in selected patients may actually have a better outcome. Now, how do you select these patients? Of course, that's a matter of, again, judgment, and this is typically immune-compromised patients, presence of a sinus, resistant organisms, and so on. But this is not very clear-cut in the literature. At the same time, we have this paper, which again is a systematic review and meta-analysis, which is showing more or less the same thing. 1 stage revision as effective as 2 stage. But here they are saying in generally unselected patients, which means that you can do it even in all your cases. So this is 1 stage. Rough reinfection rate, if you total it up, average it out, is around 7.6. And these are all the 2 stage papers, all of them, and right at the bottom, it shows that the mean is around 10%, slightly higher. Now, let's just focus for a moment on fungal infections. These are getting more and more common because for our immune-compromised patients, those who have been on antibiotics for a long time. So you have this short series of 10 cases from Germany where they have said single-stage revision works. But larger analysis of the literature looking at 164 patients suggests that 2 stage revision may probably be better than 1 stage. Now, what about the outcomes between 1 and 2 stage in terms of patient-reported outcomes? So this paper has looked at the PROMs, Oxford scores, the EQ5D, and satisfaction rates. And surprisingly, they are almost similar in 1 versus 2 stage. So the thought that 1 stage is actually better and the patient's more satisfied with it is perhaps incorrect. Now, what about the use of spacers? If you choose to do in 2 stages, you can use static or articulating spacers. Static spacers basically is just cement, usually a solid block of cement with a large amount of antibiotics. These are 2 examples. And articulating spacers allow the knee to bend, and they are of different types. They can be preformed, formed by the surgeon from molds, or using autoclaved components which have been removed. So I tend to use the last method. I use a new insert along with the autoclaved femoral component coated with a thick layer of antibiotics. And then put this in. This works as a temporary spacer. If stemmed components were infected, if they were already stemmed before, then I would use cement dowels prepared over a K-wire. And this is the patient with a spacer in place. They have good movement and they can keep walking, and till their 2nd stage is done, they're pretty comfortable. Post-op, of course, you give them antibiotics for 2 to 4 weeks, oral antibiotics for 3 to 6 months, but many of these recommendations require to be confirmed with long-term studies. Remember, the antibiotic release depends on the concentration, the surface, and the porosity of the cement. And generally, if you combine antibiotics, they are more effective. Timing of the 2nd stage is controversial and depends on essentially your judgment, X-rays, and serology, as well as a frozen section. Now, this recent study shows that the serological testing between 2 stages is unable to identify any patterns in ESR, CRP, and synovial white cells, which may be indicative of persistent infection. In other words, you're still down to your clinical judgment. So this is at the 2nd stage. We're removing the spacer, again do a thorough debridement, and put in the final implants. And these are X-rays after the 2nd stage. The disadvantages of static spacers are that soft tissue contractures may make the 2nd stage more challenging and compromise the bone stock. They may extrude or dislocate, destroy bone, and cause soft tissue damage. They may also cause abrasion with cement particles being found in the synovial membrane. In terms of articulating spacers, there's no difference in terms of infection control or range of motion, but the autoclaved components cost 1/4. But these preformed ones may dislocate, you may cause overstuffing and a fracture. Now, looking at this systematic review of spacers, static versus articulating, several hundred spacers were compared with a 4-year follow-up. No difference in reinfection, complication, or reoperation rates. Articulating spacer had slightly more range of motion. Now, at the second stage, or should you use a cementless or cemented implant? So again, this has been looked at, which is better to use. Cementless stems had a lower rate of loosening than cemented stems. The reinfection rates were similar. So the recommendation was use hybrid cementless diaphyseal engaging stems. What do you do when revision fails? You've just heard Dr. Maria. And papers have also suggested, and Jay Parvizi is one of the authors of this paper, saying that failed prior two-stage exchanges have poor outcomes after further surgical intervention. In fact, it has been recommended that arthrodesis should be strongly considered. Reinfected revised total knee, however, can resolve with an aggressive protocol and antibiotic infusion. So you might give it one try with Leo Whiteside's method of direct infusion of antibiotics into the knee. A few clinical examples of infection: first stage spacer, second stage debridement, and insertion of the final implant, and the post-op results. Slightly more damaging type of situation where you need a tumor prosthesis. Another example: infected and ununited fracture, periprosthetic fracture, after implant removal, a rod and cement, and then a second stage after 6 months. When you have extensive bone loss like this, either use stems with your spacers or a rod and a static spacer. So it's a pretty complex situation. And what about the future now? So one is several methods of diagnosis. So that's important, identifying the pathogen. A lot of research is being done, and Jay is spearheading a lot of this with the next generation sequencing. So that's in terms of identifying the bacteria. But perhaps nanobiotechnology may also be able to help in both prevention and the treatment of orthopedic implant-associated infection. And if you're interested, this is one of our papers where we reviewed the subject. And there's several strategies based on the use of nanotechnology. You can use novel delivery systems, modify the surface to repel the bacteria, use magnetic nanomaterials, quorum sensing, etc. So this is an example where you have these nanospheres containing antibiotics. So these, when they are exposed to the toxins of a pathogenic bacteria, will lyse and release the antibiotics, which will go and destroy the bacteria, which are the pathogenic bacteria alone. So that's what you can do. So I suspect that this is going to be really the future, targeting the antibiotics, targeting the bacteria using nanotechnology. With that, I'd like to thank you for your attention.